Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
But we're going to get right into our first presentation, which is by Maddie Barrett, a pharmacy resident from the University of Kentucky Healthcare, who will be presenting on fewer admissions, shorter stays, phenobarbital use for alcohol withdrawal in the emergency department.
Perfect. Thank you for that introduction. So we'll just go ahead and get started here. So the opioid epidemic has really garnered significant attention, but other forms of substance use disorder continue to have a significant impact on health and wellness. Alcohol use disorder alone affects nearly 29% of the US population over a lifetime. And globally, alcohol use disorder is actually the most prevalent substance use disorder, with over 1 million estimated cases just in 2016. Of individuals with chronic alcohol use, nearly 50% of those individuals are going to experience alcohol withdrawal syndrome, which does account for an almost 400,000 emergency department encounters annually. So alcohol withdrawal syndrome, or AWS, which is kind of how I'll refer to it throughout the rest of the presentation here, is seen in individuals who suddenly cease or reduce heavy alcohol consumption. And these individuals, as we know, have become tolerant to high blood alcohol concentrations, which normally are going to produce CNS depression through adaptations that have happened in both GABA and glutamate neurotransmitter systems. And so this abrupt cessation disrupts the adaptations that have formed and unmasks a CNS hyperactivity, which then is resulting in this constellation of symptoms for patients. It can be anywhere from nausea and vomiting and headache to diaphoresis, anxiety, auditory, visual, tactile disturbances, agitation, and tremor. And then in its most severe form, patients may also develop seizures or delirium tremens. If left untreated, AWS mortality can be as high as 15% versus 2% if it is treated. A limitation of the current literature on alcohol withdrawal is the absence of a consensus standard grading system. So you're likely all familiar with our commonly used CWA scoring to assess and monitor the severity of alcohol withdrawal. CWA scoring, as we know, is fairly subjective and effort intensive, but it's a 10-item scale with associated ranges that we can then use correspond to different categories of severity, ranging from mild to complicated. And as you can see there, just a reminder of maybe what some of those clinical findings may look like with our associated scoring ranges. The management of alcohol withdrawal syndrome does vary significantly across hospitals and emergency departments. But we know that a symptom-triggered approach has been shown to improve outcomes, including faster symptom resolution and reduced overall total medication requirements. Benzodiazepines have traditionally been the mainstay kind of first-line therapy, and phenobarbital has historically been reserved for some of our more severe or maybe benzodiazepine resistant cases due to some prior safety concerns with administration. With regards, though, to benzodiazepines specifically, we know that lorazepam and diazepam are our most commonly utilized agents, and neither has consistently demonstrated superior efficacy. Selection is typically more guided by patient-specific factors such as maybe age or hepatic function, just overall clinical severity that these patients are presenting with. The SAEM GRACE program has published guidelines recommending adjunctive phenobarbital in moderate to severe alcohol withdrawal patients being admitted to the hospital. These guidelines specifically state that there is insufficient evidence to recommend any specific phenobarbital dosing protocol or algorithm, but just more so call out that they would recommend in these patients that are presenting with moderate to severe withdrawal who may be at risk for admission. Now, a little bit more about phenobarbital. As we know, this is increasingly used adjunct or additive agent, an alternative to benzodiazepines due to its dual GABA-A agonism and then glutamate inhibition for these patients. Phenobarbital does have the advantage here with the long half-life, up to about 3 or 4 days, with an associated auto taper effect, providing more sustained symptom control compared to maybe more of the intermittent, like roller coaster control that you're seeing with PRN benzodiazepine dosing. Doses that we're using for alcohol withdrawal syndrome essentially are 5 to 10, maybe even up to 15 mg per kg per dose. Does achieve adequate therapeutic levels with minimal sedation. Supratherapeutic levels are uncommon at these typical doses. So as long as we're keeping total doses less than about 30 milligrams per kilogram, we in theory should see minimal side effects. But some adverse reactions, such as the respiratory depression, really again are mainly seen with that higher dosing if we're rapidly administering intravenously or with concurrent CNS depressant administration. So especially with benzodiazepines, but again, it's all in context of what we're using and how much of it we're using. To just talk a little bit about some of the existing literature that is out there, Rosenson and colleagues conducted a prospective randomized placebo-controlled trial looking at a single intravenous phenobarbital 10 milligram per kilogram loading dose added to a symptom-triggered lorazepam protocol, and they found a significant reduction in ICU admissions without an increase in adverse events in these patients, which supported the use of a phenobarbital loading dose as a safe adjunct for a strategy for AWS management. And then in 2024, Load and Go was a retrospective study that looked at a single dose of phenobarbital, allowing safe discharge directly from the emergency department without hospital admission in 33 low-risk alcohol withdrawal patients. No severe adverse events were reported in these patients, and so their findings too were suggestive of phenobarbital as a safe and effective ED-based strategy for low-risk alcohol withdrawal syndrome patients. Jumping into the study that we are going to discuss today, though, fewer admissions, shorter stays, phenobarbital use for alcohol withdrawal in the emergency department. Briggs and colleagues looked into evaluating the relationship between alcohol withdrawal syndrome treatment strategy and key operational outcomes, with the hypothesis of phenobarbital monotherapy showing an association with shorter ED lengths of stay and reduced 30-day ED return visits compared to benzodiazepine monotherapy or utilizing phenobarbital in combination with benzodiazepines. Looking at their outcomes, their primary outcome was the need for hospital admission from the ED following treatment. And they stratified this by medication group, which we'll talk a little bit more on the next slide. And then secondary outcomes that they were interested in included overall ED lengths of stay, returning to the ED within 72 hours for any cause, and then also returning for a hospital admission within 30 days of their ED index visit. So this was a retrospective cohort study evaluating all ED encounters for alcohol withdrawal syndrome at a single regional academic medical center from January 1st, 2020 to December of 2023. They were looking at patients who were adults, so older than 18 years, and they found these individuals through an EMR query of their ED alcohol withdrawal order set. Patients were excluded if they arrived to the emergency department as a trauma alert, if they were intubated, or if they received oral medications for withdrawal management. These patients then were categorized into 3 mutually exclusive exposure groups, so the phenobarbital only group, a benzodiazepine only group, or a combination therapy group. So these patients received both IV phenobarbital and a benzodiazepine during the same encounter. The decision to administer one versus another was at the discretion of the treating physician. The phenobarbital dosing followed a standardized regimen that the hospital had implemented within the last year. So it was an initial 260 milligram infusion over 30 minutes with an optional 130 milligram infusion 30 minutes later, again at the discretion of the treating physician. They did report that diazepam, lorazepam, and midazolam were all used as benzodiazepines, but in terms of dosing and how many patients received each was not reported. Variables collected include demographic information, triage vital signs, CWA scores, the medication exposures, ED lengths of stay, patient disposition, and then return visits. CWA scores were collected for these patients if they were documented. However, if they weren't documented, then treatment decisions were made by bedside physician assessment. Descriptive statistics were performed with chi-square testing for categorical values, and either Kruskal-Wallis or students' t-tests were utilized for numerical values depending on their data distribution. And then logistic and multivariate regression analyses were used to identify factors associated with admission while controlling for any potential confounders. So looking at their population, there were 1,170 adult patients treated for alcohol withdrawal within their convenient sample timeframe of those 2 years. Of those, 777 encounters were identified that included 549 patients meeting eligibility criteria. So most of these patients were white and male, with patients who were admitted being slightly older than patients who were discharged, so a median age of 50 years versus 46 years, but overall a median age of 48 years. And then sex and race were both not associated with disposition here. Looking at patient disposition from the ED, so of those 777 encounters, 318 of them were discharged directly from the ED. There were 48 admitted to the ICU, and then 411 had a floor admission, but what kind of floor they were admitted to wasn't reported on, so unsure of what that included. But now let's talk about some outcomes. So starting with their primary outcome of hospital admission rates, the phenobarbital monotherapy group had the lowest admission rate of the three at 52.1% of patients versus 62.4% in the combination group, and then 74% of patients were admitted in the benzodiazepine only group. This comparison here shows a statistically significant difference between admission rates when patients received phenobarbital only or the combination group compared to the benzodiazepine group. So if they received phenobarbital at all, that's in that top listed group versus if they received benzodiazepines only. And so here you can see that the phenobarbital group, as you would expect based on the last slide, had the lowest admission rates at 55.6% versus that 74%. Although I also do want to call out that the phenobarbital or phenobarbital benzodiazepine combination group did account for a total of 81.2% of those 777 encounters, so a much larger portion of patients. Excluding patients who received benzodiazepine only, total number of encounters drops to 631. Here we can see comparing that the two groups who had a phenobarbital administration, there is again a statistically significant difference still between phenobarbital only versus that combination group, with the phenobarbital only group having the lowest rates of admission at 52.1% versus 62.4% here. So looking now at more of their secondary outcomes returning to the emergency department and requiring admission, of those patients that returned to the ED, alcohol withdrawal, the most common reason, and accounted for 23 encounters, or just under 35%. And 13 of those patients then went on to require hospital admission, but had an unknown disposition for either the ICU or floor. Patients returning for non-alcohol related reasons, so for social issues or other medical conditions, were less frequently admitted compared to those that did have recurrent alcohol withdrawal symptoms. So here we can see some of our overall return at admission rates. So overall return and 30-day admission rates were similar between all of the groups. Importantly, though, I think to call out that the phenobarbital monotherapy group was not associated with an increased risk of either early or late return visits, reinforcing some of that discharge safety after phenobarbital administrations directly from the ED if the patient was otherwise appropriate for ED discharge. Looking at the ED lengths of stay, so the phenobarbital benzodiazepine combination group did have the longest median ED length of stay at 10.3 hours, which was statistically significantly longer compared to all discharged patients. And then the phenobarbital only group had the shortest median length of stay at 5.8 hours. And also, they did have the fewest median drug administrations called out by the authors, with 1 compared to 2 administrations in the other groups. So not a substantial difference, but a difference that they did call out. Next, we have the initial triage assessment. So this included characteristics that you can see listed here. And of these, the authors emphasized the initial heart rates differing significantly between treatment groups, as the combination phenobarbital benzodiazepine group was associated with increased heart rates, and the benzodiazepine group associated with a decreased heart rate. However, I would like to instead call our attention more to the CWAS scores documented. So of the 777 total encounters, only 344 encounters actually had CWAS scores documented. And I think this better illustrates the patient population and them consisting of mild to moderate withdrawal, with medians in all 3 groups being on that lower end of our moderate score range. Looking at changes in vital signs by treatment group, so they did vital sign analyses for discharged patients. Those included 302 of the 318 total patients that were discharged, as 16 of them had no repeat vital signs documented after treatment. The greatest reduction in vital signs was observed in the combination group and was reported to be statistically significant for heart rate and both systolic and diastolic blood pressure. However, I don't think these changes are necessarily clinically significant, given that their baseline heart rates were in the 100s and their systolic blood pressures were in the 140s. We know these patients with alcohol withdrawal often are going to present hypertensive and tachycardic, which does leave wiggle room for expected reductions in these vital signs after treatment. Also, just want to draw attention to the baseline vitals being stratified by disposition initially, if you notice that on the previous slide, but then here are being stratified by treatment group after the intervention. So that does limit our ability to kind of directly compare the before and after treatment changes across groups. Looking at triage CWAS scores, so they were documented in 344 ED encounters, with higher median scores being in admitted patients versus our discharged patients, so median of 14 versus 12 respectively. Overall, the median score for all patients was 13. Discharged CWAS scores, like I said, were documented for 172 patients, and the median score for those patients was a 5 at discharge. And then among the 105 patient encounters where both a triage and a discharge CWAS score was documented, the median drop in score was by 7. So patients receiving phenobarbital containing regimens did have greater CWAS reductions, greater than or equal to 7 overall points dropped, compared to the benzodiazepine monotherapy group. And again, of note, though, I do want to call it that only 33% of encounters with treated patients had documented both triage and discharge CWAS scores, so a fairly low percentage of those patients. So the authors here concluded that phenobarbital monotherapy was associated with both lower admission rates and ED lengths of stay compared to both the combination group and the benzodiazepine monotherapy group. Their identified trend of combination therapy being associated with prolonged ED lengths of stay is consistent with existing literature. The authors also conclude that phenobarbital monotherapy required fewer medication administrations overall, which could be operationally advantageous from a staffing time and resource utilization standpoint. Additionally, they found no difference in rates of return necessitating admission between groups. Looking at strengths and limitations from their perspective, they did include this analysis of ED encounters rather than unique patients. So having likely more encounters to include versus they would look at only patients and not include if they returned for a second or third or fourth time. And then also they utilized the ETHIN, which is basically a regional health information exchange, so that they could ideally capture return visits across regional hospitals and not just specifically to their institution. On the flip side, limitations included that their treatment assignment was not randomized. The ED alcohol withdrawal order set does pre-select as needed benzodiazepines, so that could have impacted how many patients were receiving the benzodiazepines versus just being in the phenobarbital monotherapy group, where it wasn't necessarily an intentional choice to include benzodiazepines or not if it was pre-selected for them. The benzodiazepine that was used and their cumulative doses were not reported. Patients who received oral benzodiazepines were excluded from the study. There were no safety outcomes assessed, and then there was inconsistent CWA score documentation across the board. Looking at kind of the study overall from my perspective, I think there are a lot of things to discuss. So starting with patient selection bias, if these patients were treated outside, or if there were any patients treated outside of their ED alcohol withdrawal order set, they were not going to be captured on how they pulled their patients from the EMR. And also patients who were receiving any sort of oral regimen were excluded, as they were assumed to be less symptomatic than patients receiving the IV medications. And they said that documentation was inconsistent. I think this makes patient selection a little bit impractical and potentially misleading, which is going to further skew the study population. And then also, like we talked about, the patients already had fairly low CWA scores to begin with. So it was interesting that they chose to call out that patients receiving oral medications were likely less symptomatic with lower overall CWA scores. The under-characterized baseline demographics, they had several key clinical variables missing, including weight to help contextualize the milligram per kilogram dosing of the phenobarbital. There was no documentation of comorbidities or relevant past medical history. So did these patients have histories of seizures or epilepsy that we would want to know about? Concomitant medications were not included. And then we also didn't know if they had any sort of like liver dysfunction. So all of these things are overall limiting our understanding of baseline risk and overall picture of the patient population. Non-standardized clinical assessment we talked about, CWA scoring was very inconsistently documented within the chart. There was missing drug intervention and dosing data, with total doses administered being missing and inconsistently reported. And given the relatively narrow dosing range of phenobarbital compared with benzodiazepines, it would have been nice to know what those doses looked like for patients. And it was also unclear whether they were targeting dosing with CWA or RAS endpoints to help kind of guide their therapy. There were no safety outcomes evaluated, and then also just a very limited generalizability overall with the missing and incomplete data. So overall, the conclusions of the study are very limited by all that substantial missing and incomplete information. This both, I think, significantly reduces the internal validity and generalizability, making it really difficult to try and determine applicability to other patient populations, given that you really don't know much about the characterization of the study cohort. Additionally, the reported reduction in admissions is consistent with existing literature, and it's not super novel or meaningfully additive to what's already out there. More importantly, I think the study falls short in its ability to meaningfully inform any sort of clinical practice, as the baseline patient population is poorly described and interventions are very broad and inconsistently characterized. So the lack of specificity here, I think, makes it difficult to translate into actionable conclusions or determine how we would apply this to a given patient population with real-world implementation. So with all that, if anyone has any questions, I am happy to answer them.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of these journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.